Hello everyone, today we'll be talking about fluid distribution and half-life of IV fluid in inflammation and septic shock. Say you're called for a blood pressure of 90 or 50 in a patient who just received 30 cc's per kg of fluid in the emergency room. While you're walking to the room, your thoughts going on in your mind. Should I have to give more fluids to this patient? And how much should I give and how fast? And will giving this patient more fluid will cause more fluid overload at this time? And what about albumin? Should I use pressors? And so on and so forth. So all you need to understand is the role of fluid in hypotension and fluid kinetics in inflammatory state. And once you know this, you will have a deeper understanding of these concepts and you should be able to come up with a good plan. So why do you give IV fluid for resuscitation? Well, the main reason for IV fluid is to improve the cardiac output so that you can improve the perfusion to the organs. And the only fluid that works to improve the cardiac output is what remains in your intravascular space. So the question remains, how long and how much of IV fluid will remain intravascular after a given time? We have discussed some aspect of this in normal person and hypovolemic person in the previous lecture. We'll discuss the effect of inflammation in the distribution of the fluids. To recapitulate from the previous lecture, when you give IV fluid to the patient, the first thing that happens is it redistributes between stressed and unstressed compartment. Some of it will leak into the interstitium, where it remains in the aqueous phase of interstitium, which slowly equilibrates with the gel phase, but most of it will return back via lymphatics into the vascular compartment. And finally, most of it will be lost through urine. Different pathologies affect all these 5 processes differently and therefore require different strategies for fluid management. So let's understand what happens to all these processes in inflammation. The commonest example we'll consider will be sepsis. Since hypovolemia is one of the main features of sepsis, please review my lecture on fluid resuscitation in hypovolemic shock, as some of the principles will be similar due to hypotension. So let's look at the effect of inflammation on stressed and unstressed compartment first. The role of stressed compartment is to generate a blood pressure, and it is the mean arterial pressures that helps achieve the mean perfusion pressures. We'll learn in a later lecture that mean arterial pressure is just a surrogate of tissue perfusion. If you want to read more about it, please see the references below. Inflammation affects your stressed and unstressed compartment in 3 ways. First, by causing vasodilation, which results in relative hypovolemia, decreased intravascular volume, and this happens as patients have loss of appetite, decreased PO intake, vomiting, diarrhea, etc. during inflammatory response. That results in absolute hypovolemia. And also some of the fluid is going to leak into the interstitium, thereby decreasing the volume of the stressed compartment. When your perfusion pressure drops, it stimulates your baroreceptor and JG apparatus, and this results in your sympathetic nervous system and renin-angiotensin aldosterone system activation. They cause vasoconstriction, venoconstriction, cause tachycardia and increased stroke volume to increase the cardiac output and decreased urine output. So you give fluid initially to fill up the intravascular compartment, and you do this so that you can reduce the stress on the system by decreasing the sympathetic nerve system and renin-angiotensin system activity. And this is the main principle behind giving 30 cc's per kg of crystalloid when you encounter sepsis. When you give fluids, you reduce the sympathetic nervous system and renin-angiotensin system activation. Now that was early sepsis, but as the sepsis continues to worsen, you will have worsening vasodilation and capillary leakage, and your patient can become more hypotensive despite your and patient's best effort. And we'll talk about the timeline of sepsis in another lecture. Let's look at the effect of inflammation on net capillary filtration. And this is your modified Starling equation. All the 4 factors are affected by inflammation. Your hydrostatic pressure gradient, which is governed by your capillary pressures, can drop in case of hypotension, and that can reduce the amount of net filtration. In the previous lecture, we have looked at this graph where reduction in mean arterial pressure decreases the clearance from the capillaries. However, understand that P capillary can sometimes increase locally as you are losing capillary autoregulation due to the inflammatory mediators. The most talked about is increase in permeability, And this can increase by 2 to 3 times during inflammation, depending upon the injury to glycocalyx, degree of inflammation, and your capillary stretch. And unfortunately, most of the reviews will talk about this aspect of sepsis when they're talking about fluid movement out of capillaries. There are other factors like drop in your Staverman's reflection coefficient as your endothelial injury and glycocalyx disruption occurs. And this will result in increased filtration as well. And as some of your albumin leaks out, your oncotic pressure of the plasma is going to drop. Therefore, that will also slightly increase the net filtration. So the net capillary filtration will depend upon how these factors change with inflammation, and most commonly, the net filtration rate increases. So there is decrease in half-life of the IV fluids that you give. However, the most important factor that governs the net filtration, pressure in the interstitium. So just to give an example, when you have swelling occurring in inflammation, it happens 20 to 100 times faster than what increase in the permeability can explain. What we have found that during inflammation, your interstitial pressure can drop to as much as negative 150 millimeters of mercury. Remember that normal P interstitium ranges from 0 to -2 in various organs. And just to give you another number, net filtration pressure gradient in a normal person is about 0.6 centimeter of water. In endotoxic shock models, interstitial pressure have been seen to drop to as much as -20 millimeters of mercury in vivo models. And because of this, your hydrostatic pressure gradient increases by a lot. So why did our interstitial pressure become so low? In the previous lecture, we understood that interstitium is made up of cellular and connective tissue cell, and they provide tension to the collagen and glycosaminoglycan network via the beta-1 integrin system. Think about beta-1 integrins as springs under tension. And tension on collagen and actin fibers prevents their expansion, so creates a negative interstitial pressure. Normally, your interstitium has subatmospheric pressures, about 0 to -2 centimeter of water, except in solid organs where it is a little positive. When you have inflammation, the pro-inflammatory molecules such as interleukins, interferons, and tumor necrosis factor release the alpha-2 beta-1 integrins. Therefore, there is unopposed action of your alpha-V beta-3 integrins, and their unopposed action results in negative pressure up to negative 150 millimeters of mercury. And this results in increased capillary filtrate. So inflammation-induced changes in the interstitium is one of the most important determinant of net filtration. Other factors do have some role to play, but can explain only a small percent of increase in capillary filtration rates. So drop in P interstitium results in more rapid loss of fluid from intravascular space to interstitium in sepsis. And this is the main difference in fluid distribution between a hypovolemic shock and a septic shock. And this is why fluid resuscitation in hypovolemia differs from sepsis. We've been taught traditionally that about 20% of the crystalloid will remain in intravascular compartment while 80% leaks out. However, extreme negative pressure in the interstitium will certainly change this equilibrium, and much lower amount of crystalloid will remain intravascular. There is no human studies on this regard. However, it would seem very plausible that most of the IV fluid that you give in sepsis leaks out and only a small quantity remains inside the vessels. Since the interstitium can hold a lot of fluid, it's easy to see why a septic patient will hold a lot of volume in the interstitium. And as you give more fluid, the negative pressure interstitium is going to hold on to a lot of fluids. So one of the question arises is, why can't lymphatics return the fluid that leaks into the interstitium back into the vascular compartment? One of the problem is because your P interstitium is so low, the movement from the interstitium to the lymphatics is compromised. Also, in the previous lecture, we learned that the lymphatics are actually active pumps and not passive. There are a lot of factors affecting contractility of the lymphangion, and norepinephrine and phenylephrine are good stimulator of lymphatic function. However, stimulation of your endothelial nitric oxide synthase trumps them all. Most of these actually work through induction of nitric oxide or its inhibition. Nitric oxide is the major regulatory component which suppresses the lymphatic pumping. So when your body makes nitric oxide, it decreases the frequency and amplitude of lymphatic contractility. In inflammatory states such as trauma, sepsis, burns, and even major surgery, nitric oxide prevents the lymphatic function and contributes to accumulation of fluid in the interstitium. Inflammation also prevents the normal functioning of the primary valve of the lymphatics, and this results in less efficient clearance of all these inflammatory molecules, and they accumulate in the interstitium, thereby enhancing the interstitial and lymphatic inflammatory reaction. Lymphatic system in inflammation is area under research at this point of time. What we know so far is that sepsis leads to structural damage of pulmonary lymphatic vessels and breakdown of lymphatic endothelium, and your lymphatic barrier is dysfunctional. One of the interesting studies that came out was this vascular endothelial growth factor C, which improves the lymphatic drainage by rejuvenating lymphatics in sepsis, and this showed some improvement in survival in animal models. We know that during hypotension, urine output drops because of autoregulation, increased angiotensin II activity, and glomerulotubular feedback. However, the common misconception that decreased urine output in sepsis happens because of decreased renal blood flow and acute tubular necrosis is misfounded. You can actually develop renal failure and low urine output in absence of renal hypoperfusion and clinical signs of hemodynamic instability. In sepsis, it has been shown that sometimes the renal blood flow can be normal or even increased, and patient will still develop acute kidney injury. One of the things to note that the rate of acute tubular necrosis, which is deemed very common, is seen in less than 5% of AKI in sepsis. This is a very long topic by itself, so I would recommend reading this article. The links are in description below. In short, the mechanism responsible for sepsis-induced kidney injury are mostly microcirculatory dysfunction and metabolic reprogramming, and less of it is related to hypoperfusion and acute tubular necrosis. So to summarize so far, in sepsis you have a high rate of capillary filtration and a lower rate of lymphatic return, and this is the primary reason of fluid accumulation in the interstitium. And interstitial fluid can have some negative effects as shown in this table. You can review this article. I have put a link in the description below for you to go through it. So let's look at the complete model of an inflammatory state. You have got increased net capillary filtration into the interstitium, increased accumulation of fluid in the gel phase of the interstitium, and decreased lymphatic return along with decreased urine output. So when you give isotonic crystalloid to a person in any inflammatory state like sepsis, you are trying to aim to improve the mean arterial perfusion. However, while you are doing that, the fluid is going to leak into the interstitium and accumulate there because of the negative interstitial pressure and increased permeability. Decreased lymphatic activity will also augment this process. Since the fluids are going to seep out in sepsis, the main question remains, how long do the IV fluid last in the intravascular compartment? Unfortunately, there are not any studies which look at the distribution or half-life of crystalloid in septic shock patient. Most of the reviews that will talk about this will extrapolate the data of fluid distribution in a normal person or those undergoing surgery or anesthesia. And extrapolating to septic shock is, in my opinion, entirely erroneous. Even though there's some similarity between sepsis and anesthesia and surgery, septic shock has a very different pathophysiology. If you do find an article, please feel free to share in the comment section below. So what do we know so far? There was one study that looked at the half-life of ringer lactate in patient undergoing cholecystectomy or appendectomy for cholecystitis or appendicitis before general anesthesia. And they found that the half-life of the ringer lactate was either shorter or slightly longer in cholecystitis or appendicitis, with more fluid accumulation in the interstitium and decreased urine volume. The study concluded that there was no association between the volume kinetics of ringers and the degree of inflammation. However, these patients were not in shock state and they were just in early sepsis, and also kinetics were affected by anesthesia. So we cannot really extrapolate any good conclusion from this study. So at this point, we just have conjunctures and not any specific study on the crystalloid. T-half of the crystalloid in sepsis will vary per the severity of inflammation, which should decrease the half-life, and the degree of hypotension, which should increase the half-life of the fluid. In my opinion, the half-life of crystalloid is possibly lower than normal person, but may not be very low in very hypotensive patient. From the previous lecture, we know that the half-life of crystalloid in a normal person is about 30 minutes and it increases to 80 to 150 minutes in a hypovolemic patient. What about colloids such as albumin? This was a study done in 1985. However, the N is only 6. What they found was in septic shock, your transcapillary escape rate of albumin, which is normally around 5%, increased to 15. That means it was increased by 200% in patients with septic shock. This was another study which gave 20% albumin to 66 patients with septic shock and 26 controls. And they found that the serum albumin concentration decreased significantly faster in septic patients than healthy controls. The albumin leak was found to be around 50% faster when compared to the controls. One of the things that you can use albumin in this regard is calculating albumin leakiness index, which means that how much of albumin remains intravascular at 4 hours, and this can give you some idea about leakiness of the capillaries. So one of the things that we know that albumin certainly lasts longer than crystalloid in sepsis. In the previous lecture, we learned that the half-life of albumin in normal person is about 16 hours and can be much longer in hypovolemic patient. In septic shock, it is possibly much shorter, possibly ranging between 5 to 8 hours. However, understand that despite albumin lasting longer in the intravascular compartment, multiple randomized controlled trials have not shown any benefit of colloids over crystalloid in affecting mortality in these set of patients. Another interesting thing to know is that use of vasoactive drugs like norepinephrine, epinephrine, dobutamine, and phenylephrine can also affect half-life of fluid. This was an interesting study done by Hahn et al. And they studied 4 drugs, norepinephrine, phenylepinephrine, dopamine, and esmolol in a septic model of sheep. They infused 20 ml per kg of ringer lactate over 30 minutes and looked at half-life of this fluid. And you can see that in controls, the half-life of the ringer lactate was around 100 minutes. But when these were given norepinephrine, half-life was much longer than controls, around 120 minutes. But when you look at the phenylepinephrine and dopamine, you can see that the half-life of the fluid was much shorter. It was around 50 minutes, which is half of that seen in control. So phenylephrine and dopamine seem to accelerate the distribution out of the intravascular compartment. To understand this graph, look at the red lines, which show your intravascular volume. And this looks at the dose response curve. As you stimulate more alpha-1, you can see that the rate of leakiness increases and the half-life of the fluid decreases when you stimulate alpha-1 receptors. And when you stimulate beta-1 receptors, the half-life of the fluid gradually increases. So this might be one of the another reason of using norepinephrine as your first choice in pressure as compared to phenylephrine. From the previous lectures, we learned that the distribution of small amount of crystalloid, like 5 ml per kg, might be limited only to the plasma volume. Because for small volumes of infusion, the interstitial fluid matrix has too low a compliance to permit volume expansion. However, we don't know the interstitial compliance in sepsis. We are certainly extrapolating this data from the healthy person and patients with hypovolemic shock. So it makes sense that we give small boluses more frequently and reevaluate rather than give large boluses at one time. We also learned the rate of infusion also affects the half-life of crystalloid. Again, that's an extrapolation from normal healthy volunteers, but it does make sense that if you go a bit slower, your half-life of fluid will possibly be longer than when you give your fluid faster. So if your patient is fluid responsive and relatively stable, it might be better to give that 500 cc bolus over 60 to 90 minutes rather than 10 minutes. However, understand that if your patient is crashing, it's better to give them a faster bolus than a slower bolus. Faster bolus achieves more intravascular volume increase rapidly. However, the slower boluses will give you longer duration of intravascular volume. How do you put all this into clinical practice? Since the inflammation is the only culprit here, the only way to reverse is to treat or correct whatever is the underlying etiology. For example, if you are dealing with septic shock, treat infection and do good source control. The best way to give fluid in these patients is to maintain organ perfusion while avoiding the fluid overload state while you are correcting the underlying disease process. So the answer is pretty difficult, and only you can answer this question because it's very time and patient specific. Whenever you give fluid, always assess the risk and benefit. The way I go about it is asking myself few questions. First, is my patient organ underperfused? Second question I ask myself is, will giving fluid help this patient improve the perfusion? That means increase the cardiac output, and that you can know by figuring out if the patient is fluid responsive. Third question I ask is, will giving fluid result in more fluid overload and cause more harm than the marginal improvement in perfusion? That means, is my patient fluid tolerant? And lastly, will vasopressor be a better choice to maintain the organ perfusion? There are many other factors that affect the half-life of IV fluid in inflammation, and this table is just a small list. So you can see that it is really complicated, and knowing exactly how long your IV fluid are going to last is going to be very conjectural. To summarize, in inflammation, accumulation of fluid into the interstitium is from multiple factors, which are possibly more important than capillary leakage. More important among them are negative interstitial pressure and lymphatic dysfunction. And future research should study these two topics. Fluid distribution in sepsis and inflammation is very complex with many factors governing the half-life of fluid. Nobody knows the right answer currently as this is very variable. However, we do have some idea. Half-life of IV fluid of both crystalline, colloid, and sepsis is dependent on the severity of inflammation and the degree of hypotension. Clinically, you can overcome this problem by evaluating risk and benefit of IV fluid before giving it to them. Just understand the fluid responsiveness and fluid tolerance of your patient. If you have decided to give fluid, that means your patient is fluid responsive and tolerant. Give fluids in small boluses rather than large boluses, unless the patient is crashing. Know that some of the volume of crystalloids will remain intravascular despite the leaky capillaries. Albumin, though, remains in the intravascular compartment for a much longer period, but the studies have not found any mortality benefit of using albumin over crystalloids. Vasopressors can also affect half-life of IV fluids, and stimulation of beta-1 receptor is possibly better than alpha-1 receptors, and this might be one of the other reasons to use norepinephrine instead of phenylephrine in sepsis. We'll talk about more clinical aspect of this when we talk about fluid responsiveness and fluid tolerance in our subsequent lectures. These are possibly more relevant questions than just knowing the volume status of your patient. Thank you. The references are in the link below.